Hello friends, welcome to the session of Conceptual Spine Connect today. A lot of candidates were requesting for classes on fractures, hence I started taking fractures again. So today we are going to talk about the cervical spine fractures. So the cervical spine consists of the occiput, the atlas, the axis, along with its ligamentous attachment, which is basically called the craniocervical junction. So this is the upper cervical spine where we have the occiput, the part of the skull. Along with that, the first vertebrae, that is the atlas and the axis. And these bones, along with the ligamentous attachment, they are in together called the craniocervical junction. The osseoligamentous complex protects the upper cervical spinal cord, brainstem, and the lower cranial nerves. So these are the important structures that are basically protected via this consolidation of the bones and the ligaments in the proximal part of the cervical spine or the upper cervical spine. So they protect the upper cervical spinal cord, the brainstem, and the lower cranial nerves. So whenever we talk about the injuries that happen, that is upper cervical spine injuries, what we see is there is a bimodal age distribution. What is this bimodal age distribution? So most commonly when we see the injuries, they are seen either in children or most commonly in old people who are beyond 60 years of age. Cervical spine injuries constitutes of 1 to 9% of the spinal trauma in children. And out of this, upper cervical spine injury in itself is 56 to 73%. In these kids, generally the head injury component is associated in 53% of the cases, and there is a 40% mortality because of these injuries. When we talk about the old people which are beyond 60 years of age, C1, C2 becomes a complex injury area in these geriatric age group patients, which accounts for 26 to 28% of the mortality, and the 2-year survival period in these individuals is 60%. So this is very important because this is asked in your MSFNB MCQs, wherein the bimodal age distribution is important, and along with that, the percentage of mortality. Non-contiguous injuries are seen in 6% of the cases of upper cervical spine injury. So hence it is important that whenever we order the investigations for these patients, we ask for the whole spine screening as well, so that we are able to see and diagnose the non-contiguous injuries before they become problematic or before they start to become symptomatic. And also we have to understand whether these non-contiguous injuries, they are stable or not. Many a times these injuries in the upper cervical spine tend to be stable, and the ones which are in the other areas are highly unstable ones. And all the focus goes on the upper cervical spine injury. And this is the reason why understanding and diagnosing these non-contiguous injuries is of vital importance. 50% of the cases are associated traumatic brain injury. Many a times these patients directly come on ventilator. Hence, getting their investigation done with respect to the brain MRI or the CT is also important. Ruling out skull fractures, ruling out traumatic brain injury, this is important. Roping in neurologists to evaluate that and ruling that out is something that we should always consider in such patients, because as high as 50% of the cases have some or the other form of associated traumatic brain injury. When we talk about the atlas fracture, it in itself, in 50% of the cases, is associated with injuries in the other parts of the cervical spine. So whenever you have a patient with atlas fracture, you have to rule out and you have to investigate and see whether the other parts of the cervical spine are fine or not. When we talk about the vertebral artery injuries, it is important. Why? Because generally the vertebral artery injury can cause fatal ischemia and brain damage. So when this happens, we have to understand, because in a lot of cases, this happens secondary to trauma itself. So Friedman reported as high as 24% of the cases having associated traumatic vertebral artery injuries. Vaccaro et al. Reported in around 20% of the cases. Cawthron had the lowest prevalence, that was 18% in his series. Whenever we talk about, unfortunately, a bilateral dominant vertebral artery injury, so many a times the patients don't have both the vertebral arteries to be dominant. One vertebral artery is dominant over the other. And in some cases, we have both the vertebral arteries exactly same in size, and that is how the dominance is of both the vertebral arteries together. So bilateral dominant vertebral artery injury will lead to fatal ischemia, cortical damage, and cerebellum damage. So that is how, whenever we deal with such patients, by doing the angios, we have to confirm in suspected cases whether vertebral artery is injured or not. Why is it to be done? Because if ever you're planning any form of intervention, you have to rule this out beforehand, because a vertebral artery injury can cause life-threatening hemorrhage on the table also. So coiling should be done for that. And along with that, if ever you can possibly, if ever there are just clots over there, so you might have to consider getting the blood flow back so that the perfusion is restored to the brain, so that we don't incur a fatal ischemia possibly. What are the associated injuries when it comes to the nerve roots? So as we know, whenever we talk about the C5, 6, 7, 8, T1 nerve roots, so they are basically the ones that supply in the arm. However, C1 and C2 nerve roots are the ones that basically just have sensory loss, which is in the posterior aspect of the occiput over here. So apart from that, we don't incur any form of motor loss in such cases if ever just the root is involved. Whenever we have patients with a complete cord injury, unfortunately, they have ventilator-dependent quadriplegia. So whenever they have this complete quadriplegia at the area which is the area near the brainstem, so the respiratory centers also don't work, the diaphragm is paralyzed, and that is how these patients are ventilator dependent. Imaging, X-rays in itself, in 85% of the injuries would possibly detect some form of the fractures in the lateral view. However, when we talk about the junctional area, that is the cervicothoracic junctional area, that won't be visible. But over here, when we talk about the craniovertebral junction, so in such cases, in 85% of the injuries, we could be able to detect some form of fracture. The diagnostic modality of choice is a CT scan with an 84% sensitivity. And the clinical criteria for routine CT imaging in high energy trauma would be depending on. So basically, what does this mean? This means that we don't actually ask for a CT image for all the patients. Whenever the patient is having a history of high energy trauma and possibly any form of further of the 5 pointers are present, that is when we basically ask for the CT imaging. So if a patient will come to you with a history of high energy trauma and they report to you with altered consciousness, occipital pain, tenderness, impaired cervical craniovertebral junction motion, lower cranial nerve palsies, motor paralysis or motor paresis. So any of these, if ever they are present on the clinical examination along with the history of high energy trauma, so these are the patients in whom you will basically ask for a CT imaging also to be done along with the X-ray. Why is it so? Because sometimes the fractures would be such that they might be missed on the X-rays. However, CT, as we understand, is a clear-cut investigation technique wherein you can't miss any fractures. Also, CT helps to understand whether the injuries are unstable, stable, how many columns are involved. So there are whether the facet is involved, how much it is involved. So these are very important with respect to our decision making. MRI is done to mainly determine the ligamentous integrity in craniovertebral junction and the cord injuries. So these are the different investigations that are used. And generally, whenever we talk about fractures, most commonly the modality of choice for us is actually MRI. However, when we talk about the craniovertebral junctions over here, instead of the MRI, it is actually the CT, wherein it helps us to make the a decision and also helps us to understand the fracture anatomy and the exact extent of the fracture in details. MRI, however, definitely will help in understanding whether the cord is injured or not. And also the ligamentous structures, which are the soft tissue structures, they won't be seen on the CT, and hence MRI would be indicated in such cases. So the first fractures that happen in the higher cervical spine, I would say, are the occipital condyle fractures. The incidence of occipital condyle fractures is 3 to 16%. The presentation is such that it is, on the either side. The patients might present to you with a minimal deficit, or they would just present to you with frank quadriparesis. High cervical spine pain is the presentation. Torticollis, that is the neck would be twisted on one of the sides and bent. The patients would come to you Reporting with headache. The mobility is impaired.